These are my disclosures. They're all out of whack. I don't know why. And again, I thought I would start with a case. One of my patients who came to see me a long time ago now, 30 years ago. She was 29, and she was a lovely young woman. She was sitting on a window ledge, and she slipped off the window ledge. You're probably going to be bored. You've heard of this before, I think.
Repetition.
Right. Anyway, she fell, and she broke her hip, which is pretty unusual in a young woman. And so somebody thought they should get a DEXA scan, and they did. And you can see that her T-scores were low. They were Z-scores, were below -2 at the spine and total hip, and actually as low as -3.1 at the femoral neck. So compared to an average 30-year-old woman, the T-score and the Z-score would be the same. She was 2.5 to 3 standard deviations below the average. She didn't really have any history that would have raised alarms. She didn't take any medications that we covered a lot of this morning that are associated with bone loss. And she had a slightly late menarche, which is associated with perhaps a slightly lower bone density at peak bone mass, but certainly not Z-scores of -3. She had regular periods, never had any amenorrhea. And the only thing in her history was that she did have a family history of osteoporosis. So on exam, she was very slender, but she did not look malnourished or anorectic or in any way. She was well-muscled and athletic, but not like a athletic amenorrhea type of person at all, just kind of normal looking. She didn't have any stigmata of Cushing's disease. She didn't have blue sclera, suggestive of osteogenesis imperfecta. She didn't have any joint hypermobility or laxity or any inflammation. She didn't have kyphosis, and she had no bone tenderness, which is a sign of osteomalacia as opposed to osteoporosis. So we worked her up for secondary causes of bone loss, which I'll come back to again and again, because in this age group, it is. Do you want me to leave this open? Is it hot in here? Okay. I didn't want to disturb anybody out there, but it's extremely important to work people at this age group up for secondary causes of osteoporosis because it's very unusual for a premenopausal woman to have osteoporosis. So she had the normal general workup, CBC, lights, metabolic function, thyroid function, celiac screen, urine-free cortisol, even though she didn't look Cushingoid at all, and they were all normal. Her mineral metabolism parameters, calcium, phosphate, PTH, vitamin D levels, and 24-hour urine calcium were normal. And she had bone turnover markers done, which were in the normal mid-premenopausal range. We were doing some research at the time, and actually it was before we really got into the research, but at that time we were doing transiliac crest tetracycline labeled bone biopsies in people with mysterious causes of osteoporosis, and she had that done, tetracycline labels given for 3 days and then separated by another 3 days and then another 10 days separated by 10 days and then 3 days of label, and then we do the biopsy 5 days later to look at bone forming surfaces. And microstructurally she had very thin porous cortices. This is green here, cortical bone, and her trabeculae were very thin and few in number and disconnected for a premenopausal woman. This is the osteoid here, and she didn't have any excessive amount of osteoid, so no osteomalacia. But when you looked at her bone formation rate, I'm not sure how well this shows up, but if you could see these two labels here, tetracycline labels along the surface, it was very low. So we treated her conservatively. This was in the 1990s. We didn't really have, maybe it was even in the late 80s. We didn't really have anything else to offer. She took calcium and vitamin D. She needed birth control, so she took an oral contraceptive. And over the next 3 years, we followed her, and her bone density remained stable, so it didn't get worse, and she didn't have any new fractures. She went through 2 pregnancies followed by breastfeeding, And thank God, you remember Dr. Cohen's talk a week before last on pregnancy and lactation-associated osteoporosis. So this is an example of a woman with very compromised bone who came into pregnancy and lactation and did fine, didn't have this type of fracture syndrome that we associate with pregnancy and lactation-associated osteoporosis. And over the years, I followed her, and every once in a while we'd reevaluate her for secondary causes, and nothing ever showed up. So I'm going to come back to her later. So you've all heard, I'm sure, this week about how to diagnose osteoporosis in postmenopausal women. And we usually do that by aerial bone density by DEXA T-scores that are below -2.5, which is below the young adult mean at the spine, hip, or forearm, plus or minus a fragility fracture. And the reason we can do this is because there have been a slew of epidemiologic studies that validate the associations between bone density and various risk factors in addition to low bone density, like age, and incident fractures in postmenopausal women. However, unfortunately, we don't have any comparable data for premenopausal women. And how do we treat osteoporosis in postmenopausal women? It's an evolving paradigm, but in general, we begin to treat if the patient has either a low T-score, they have low trauma fractures, or some people would treat if the 10-year probability of fracture by FRAX or the risk assessment scores is elevated, even in the absence of frankly low bone density or a prevalent fracture. So unfortunately, though, there's no clear intervention thresholds for premenopausal women. And so this is the problem that we have to deal with in a premenopausal woman. We really don't have a lot of really good data on how to make the diagnosis and what to do about it once we make it. So what I'm going to do today is just talk about a few general issues about diagnosis and etiology of osteoporosis in premenopausal women. I'm going to describe some of our research in looking at premenopausal women who have no apparent cause for their osteoporosis or idiopathic osteoporosis. And then I'm going to talk a little bit about management of osteoporosis in premenopausal women with either secondary osteoporosis or idiopathic osteoporosis. So, as we've alluded to already, this is an uncommon problem, and the diagnosis of osteoporosis in a premenopausal woman is much more certain if the woman has had a fracture like this patient. There's a lot of controversy on whether it can be diagnosed on the basis of just having a low bone density. So if she had presented and gotten a bone density done with no fracture, there would be people who say, big deal, she hasn't had a fracture, and they wouldn't want to make the diagnosis of osteoporosis. But because she had that low trauma fracture just sitting on a windowsill and slipping off, that validated that bone density score and allowed one to be more confident that there really is a problem. Now, you've probably also already seen this a bunch of times, and probably this week, about how we use the T-score to diagnose osteoporosis and what the categories are. So this compares, the T-score compares an individual's bone density to the mean bone density of a population age 30. And so anything with a T-score above -1 is normal, anything below -2.5 is osteoporosis. And then we have this sort of no man's land in the middle, low bone mass or osteopenia. And I show this again because these cut points were never really intended and shouldn't be used to characterize bone density in premenopausal women. In premenopausal women, the guidance of the International Society for Clinical Densitometry and the International Osteoporosis Foundation is not to use T-scores, and the reason not to use them is not because the Z-score is that much better, but just to avoid this term, osteopenia, and labeling young women with a term when really they're probably just within the normal bell-shaped curve of bone densities for their age. So we're supposed to use the Z-score, which compares them to the BMD of an age-matched normal population. And And in premenopausal women and men under age 50, a z-score above -2 is within 2 standard deviations of the normal and should be reported out on a DEXA scan as within the expected range for age. And a z-score, would you like me to move over here? So I'm not in everybody's way. So, and a z-score below -2 should be reported as below the expected range for age. And as I mentioned, we try to avoid this term osteopenia in premenopausal women. Even though z-scores and t-scores in a 30-year-old woman are basically the same, we don't have these categories of osteoporosis, osteopenia, and normal. We try to avoid the osteopenia. Now, in perimenopausal women, the ISCD now feels that the term that t-scores can be used in a perimenopausal woman, but in a young woman like our patient, not to use them. So why would a young woman have a low bone density by DEXA? So it could be that they have low peak bone mass. Genetics account for anywhere from 50 to 85% of the variability in bone mass. And it's possible that they might be in a family that just has low bone mass for some genetic reason. Also, a young woman might have had suboptimal bone mass accrual during adolescence. You know that during the ages between, around the time of puberty and before about the age of 18, you've pretty much made 95% of all the bone you are ever going to have. So up till, a couple of years after menarche in women and a couple of years later in men, but basically by 18, you've got everything you're going to have except maybe for another 5%. So if something happened to a young person while they were an adolescent during that time of bone mass accrual, that they developed asthma and had to take steroids, or they had to they suddenly developed celiac disease or something, then they might not make all the bone they were designated to make during that period of time, and could end up with a low peak bone mass. They may be of small stature. As you know, DEXA measures an areal bone density and converts it mathematically to a volumetric bone density, but it's not really a true volumetric bone density, and it doesn't take the depth of the bone into account. And so DEXA not only underestimates bone density in very small people, but it also overestimates bone density in very tall people. So sometimes people at the extremes of size may have a DEXA that doesn't reflect their actual true volumetric bone density. Another reason is just the statistical definition of a T or a Z or a T-score, because in a population of normal women, 2.5% are going to have a z-score below -2, because that's what it is. It's a z-score. It just measures 2 standard deviations on either side of the mean. And so if you're below that for some reason, you could come up with having a z-score of below -2. And similarly, a t-score in someone age 30, 5.5% of people could have a t-score below -2.5 on a population basis. So that's, on a population basis, a lot of people. Also, there's this syndrome, I don't know, I think this patient actually may have it, but what is it? It's a constitutional leanness, which is a non-pathologic state of underweight that's often familial. The patients always have regular periods, but they do have low bone density by DEXA. The significance of that is not entirely clear. We don't really know whether they have a higher fracture rate, but if you do HRPQ-CT studies of these patients, such as Fernando Garcia's and all did, they have abnormal microarchitecture and low bone strength. So we don't know why they are the way they are, but this is another syndrome, a poorly understood syndrome that could account for a low areal bone density by DEXA. That's not due to a secondary cause. The thing about low density in young women is that it's just not associated with the same risk of fracture as a low bone density in an older woman. And that's because premenopausal women have estrogen, they have muscle, more muscle than older women, they have lower bone remodeling activity, their cortices of their bones are thicker, and they have better trabecular microarchitecture and connectivity, and they also fall less, unless they're, jump out of airplanes and things with parachutes. And And so therefore, the incidence and prevalence of fractures is much, much lower in premenopausal women than postmenopausal women, even when they do have a low bone density. And that can be seen in this graph that relates T-score versus to hip fracture risk by bone density. And you can see here in the bottom we have the 50-year-old woman, and you can see that even as the bone density goes up, her risk of fracture is rather low compared to a 70 or an 80-year-old woman at the same bone density. So here we are with a 50-year-old woman, and here we are with an 80-year-old woman. T-score minus 2.5. So fortunately, even though some young people do have low bone density, they aren't really at so much risk for fracture while they're young, although they may be very much at risk of more fracture when they're old. So how do we make the diagnosis of osteoporosis in a premenopausal woman? Well, it's a little fraught, but basically if the Z-score is below minus 2.5, or if you want to use a T-score, it's below minus 2, the Z-score minus 2, or the T-score below minus 2.5, and they have a secondary cause of osteoporosis, such as glucocorticoids or hypogonadism or celiac disease, etc., you can say that woman has osteoporosis. Or if they have a history of a vertebral or a non-vertebral low trauma fracture at a major site like our patient, we would make that diagnosis whether the bone density was frankly low or not. But what do we think about a premenopausal woman who has a low bone density but no secondary cause and no fractures? So neither the ISCD or the IOF would say such a woman has osteoporosis. And I'm not really sure that's really right. And I'll show you a little data later to support my sort of perspective. So how do we evaluate women who were concerned about osteoporosis? So the goals of the evaluation are really one goal with a subthing. We want to identify if there is a secondary cause of osteoporosis, especially if it's a treatable cause. And the reason for that is because treating the secondary cause is often more effective than treating the osteoporosis. And what are the secondary causes? There's zillions of them. I'm always trying to find ways to add to this slide without making it 2 slides. But, you know, there are a lot of conditions that are associated with osteoporosis. But in fact, most of them are on this slide. The most common causes of osteoporosis in premenopausal women are glucocorticoid excess, just like it's the most common cause of secondary osteoporosis in other groups, and either endogenous from Cushing's or iatrogenic from therapy, like a transplant patient. And then anything that's associated with premenopausal estrogen deficiency. So late menarche, hypogonadotropic hypogonadism, athletic amenorrhea, anorexia, et cetera, anything that causes estrogen deficiency before menopause, these are the most common causes. And this is then followed by GI diseases like celiac disease, IBD, malabsorption, medications, alcoholism, primary hyperpara, OI, and then idiopathic, which is probably heterogeneous. Who should be evaluated for secondary causes? If we don't recommend measuring bone density in premenopausal women because it's very rare for it to be low, so it's not cost effective, and plus we don't really have anything really good to do about it, so we don't usually measure it. But if it should be measured for some reason, then and somebody does have a low Z or T score, then I think they deserve to be evaluated for why that might be, because you may be able to uncover a secondary cause. And then if you have a fragility fracture or a prevalent vertebral fracture, which is extremely unusual in this age group, prevalent vertebral fractures in young men and women, especially women, occasionally men can get them from sports injuries, but it's still pretty rare. You really need to be looking for you evaluate them for osteoporosis. The IOF suggests you should have more than one fracture to do this, to warrant a workup, but I wouldn't agree with that. So how often would you find a secondary cause of osteoporosis in a young woman? That kind of depends on what sort of practice you have. So if you're in a rural community or a general endocrinologist and you're seeing all comers, you probably wouldn't see that many. And most of the women or young men even, that you would see with osteoporosis at that age, most of them would have a secondary cause. And in a population-based study of men and women between the ages of 20 to 44 who presented with fractures and low BMD, and this was the Rochester, Minnesota study of the Rochester Epidemiology Project, 90% of those people had a secondary cause. But if you're here at a tertiary referral center, then a lot higher proportion of your patients are going to have no cause that you can figure out. So most of the series that have been published, about only half of them had a secondary cause. So it kind of depends on what milieu you find yourself. What do we do to evaluate it? Well, history. Have they had fractures? Do they have a family history of fractures? That might suggest a genetic situation. Do they have a history of early tooth loss, which could reflect some genetic disorders? Kidney stones in the patient or their male resident relatives or female relatives can suggest idiopathic hypercalciuria, which is a secondary cause of osteoporosis. An abnormal menstrual history, are they dieting? Do they have bulimia? Do they have anorexia, eating disorders? Subtle GI symptoms can sometimes be consistent with celiac disease. And then medications. And then physical exam, obviously look for stigmata of Cushing's disease, thyroid toxicosis. Systemic mastocytosis is a very rare cause of secondary osteoporosis, and the patients may often complain of hives. And then if you sort of run your fingernail or a sharp object just over their skin, they'll have this line, dermatographia, that will swell up. And then obviously connective tissue disorders like OI and Ehlers-Danlos. So I usually start with a pretty simple evaluation, CBC, usually liver function test, metabolic panel, obviously a TSH, because thyroid toxicosis can cause osteoporosis in young women, vitamin D levels, and then I always get a 24-hour urine for calcium and creatinine. I don't get a spot urine because it doesn't really tell you anything. But you need to know over the past 24 hours how much calcium that person has put out. And it doesn't necessarily, it kind of goes in with your thinking process. For example, if somebody has some subtle GI symptoms and a low urine calcium, it could suggest they're malabsorbing or they have celiac disease. If they have an extremely high urine calcium, it could suggest idiopathic hypercalciuria. And while I'm at it, I usually get a free cortisol just because it's a nuisance to collect that urine, or else if I don't do that or they come from somewhere else, then I would get salivary cortisols. And then we do additional laboratory tests as indicated, looking for problems with estrogen deficiency, the PTH125D axis, things that might suggest malabsorption, hematologic disorders, inflammation, tryptase and histamine, and then sometimes if I suspect OI or hypophosphatasia or Ehlers-Danlos, we would do specific genetic testing. And more, I think we're probably going to be seeing patients coming in and asking for whole exome sequencing for mutations in Wnt and LRP56 and other genes. What about bone turnover markers? If they're not that helpful, in my opinion, I'll show you some data in a minute. If they're low or normal, it could suggest there was prior bone loss and everything's pretty resolved now, or that they just had low peak bone mass. If they're high, it could suggest ongoing bone loss, like from inflammation, rheumatoid arthritis, etc. But they really have a very wide normal range, and they're highly variable. They have to be interpreted according to age, because obviously young people who are growing, they're physiologically elevated, and they are also high after fractures for quite a few months, so that if the patient's had a recent fracture, it's not going to be of very much help. What about bone biopsies? Well, as I mentioned, tetracycline labels bone where active mineralization is occurring, but bone biopsies are not really widely available, and they're primarily a research tool. Sometimes if I can't find anything and the patient's having ongoing low trauma fractures, I might get one. I have found the odd thing, like a case of unsuspected Gaucher's disease, etc. May identify some kind of problem with bone material properties that may make the bone more fragile. And depending on what we see in terms of the bone remodeling rate, they might guide therapy. But again, a research tool not widely available. So I'm going to talk a little bit about idiopathic osteoporosis, or IOP. And just as an operational definition, this applies to premenopausal women and men under the age of 50 who are otherwise healthy and have normal gonadal function and have never had abnormal gonadal function as far as anybody knows. And then after a workup, they have no secondary cause of osteoporosis. These patients are most usually Caucasian, although not always, and they often present in their mid-30s, like this patient, or late 20s, with one or more low trauma fractures. Often these fractures cluster over a 5 to 10 year period, and then they seem to not go away, but not happen further. They may present during pregnancy or lactation. That's certainly a theory. And it can be mild, or it can be devastating. And I've had patients with, for no apparent reason, 4 or 5 or 6, and one even as many as 8 vertebral compression fractures with no trauma. So what about if you have an isolated low bone density in an otherwise healthy woman? Is that osteoporosis? Is that IOP without fractures? We don't really know. We don't know whether the short-term fracture risk is increased. And until we have some data suggesting that even in this situation, the microarchitecture is abnormal. We did a study in the late 2000s, which was a cross-sectional case control study of 40 women who were normal, 45 women who had IOP and had fractures. And they had anywhere from 1 to 12 adult fractures, and 25 had more than one fracture. The mean age at first fracture was 30, and the fracture types were vertebra, ribs, hips, pelvis, forearm, humerus, ankle, and metatarsal. We didn't include anybody in the study if they had just metatarsal fractures alone, because who knows what they mean. And then we had a low BMD group, which proved to be really hard to recruit to, because just at the time we were starting the study, the word went out not to measure bone density in premenopausal women, so it turned out to be much harder than we thought to recruit. But in that group, we didn't have anybody with an adult fracture, but we did have about 16% who had had high trauma fractures, not low trauma fractures, like involved in a car accident or a skiing accident. And then about a quarter had childhood fractures. So just looking at the study group, they were well matched in terms of age and height, but the controls were heavier than the fracture and low BMD group, both in terms of weight and BMI. So all the analyses that I'll tell you about now are adjusted for BMI. Despite the difference in weight, we didn't find any difference in whole body or trunk fat or caloric intake, reproductive history. There was no difference in any estradiol parameters, vitamin D metabolites, most bone turnover markers. We did find a slightly higher PTH, I'll show you those data in a minute, and a slightly higher, although normal, TRAP5B, which is an osteoclast marker. And we found that there was a direct relationship between PTH and TRAP5B and also other bone turnover markers. So this was a completely normal PTH, but it seemed to be associated in these women with increased bone turnover. We did find that the family history of osteoporosis was more frequent in the subjects, and we did find a tendency toward more SSRI use in the subjects. You can see, here's the PTH data, here's the control patients. The normal range is 10 to 65 for that assay. These people were significantly higher, but still normal, and so was 29 or 30 on average. The TRAP5B was higher in both the two groups of affected women. And as I mentioned, there were these direct associations between PTH and all the bone turnover markers. But interestingly, no control patient had a PTH above 38, but about 20% of the IOPs had PTHs above 30. And we always say that the PTH range of 10 to 65 is really for older people, and that if you have a woman or a young man with a PTH above 40 in that assay, and they're young, then you have to be suspicious that something's going on. So I think I'm always very suspicious, even if the PTH is in the normal range, but if it's in the upper end of the normal range, I think that could be a clue to a subtle secondary cause like undiagnosed malabsorption or idiopathic hypercalciuria with renal calcium losses. Now in men with IOP, there's been multiple studies that have shown that they have low serum IGF-1 levels. So we kind of expected we were going to see low serum IGF-1 levels in these women, but we really didn't. We didn't see any difference. And in men, the serum IGF-1 levels are directly associated with bone formation. So low levels of IGF-1 are associated with lower levels of bone formation rate on bone biopsies and with bone turnover markers. We didn't find that. We didn't find any association with bone density. We didn't find any association with bone turnover markers in our women, in contrast to what we had seen before when we looked at men. Obviously, the DEXA measurements were lower in both groups of affected patients, but we wanted to ask, what about volumetric BMD? Is that also lower, or is this just a problem of measurement, and that we're not really measuring total volumetric BMD? So we used central QCT, which is a measure of volumetric bone density, to measure trabecular volumetric BMD at the spine, and it also can measure trabecular and cortical volumetric BMD at the hip, and also cortical thickness. And it takes into account the smaller bone size or larger bone size of an individual, because it's looking at the entire bone. And this is data of the central QCT data in the IOP expressed as % lower than controls, and the fractures are in blue, and the low BMD is in orange. So you can see at the lumbar spine, that's every measurement, the integral, which means the whole vertebral body, and the trabecular only was lower in both, or 30% lower down to. At the proximal hip, again, both were significantly lower, and at the femoral neck, cortical thickness was lower, cortical area was lower, and stiffness by finite element analysis at the spine and hip. So even though the low BMD group had not had any fractures, they did have lower stiffness and lower volumetric bone density, thinner cortices. We also did a little calculation to determine whether aerial BMD by DEXA as a z-score predicts whether they'll also have a low volumetric BMD by central QCT. So we used the CQCT results from the controls to calculate z-scores for the IOP subjects. And we found that at the spine, almost every subject who had a z-score below -2 by DEXA also had a z-score below -2 by central QCT. And the positive predictive value of DEXA for a central QCT z-score below -2 was 95% at the lumbar spine, and also very good at the total hip. So I think that tells you that if you do see a low bone density, you may not be able to be totally sure the person has, this is by DEXA, osteoporosis, but they probably will also have a low BMD when you look volumetrically. We also used HRPQCT to look at the distal radius and tibia by HRPQCT. We measure here this area of the radius and this area of the distal tibia using this small CT scanner. And this is a representative tibia from a normal person, normal woman. This was a representative tibia from a woman with one of the fracture women, and you can see how much thinner the cortices are here and how many fewer trabeculae there are with all this dropout in the middle. And then this was a low BMD woman without a fracture. Again, you can see pretty much the same picture as the fracture patient. And then we looked at bone biopsies on all of these women, and here was a typical control biopsy. This is just the trabecular bone. The cortex has been taken off. These are micro CTs of the biopsy core. Here we have a fracture patient. You can see very many fewer trabeculae, much less bone there. And here's a low BMD group. And then looking at the cortex by two-dimensional histomorphometry, this was a typical cortical thickness in a normal woman. Here we have a great big hole in the cortex and lots of other holes here in a fracture patient, and also much thinner, more trabecularized inner cortex here in a low BMD patient. So just to summarize what we found, whether we use central QCT of the hip and spine, peripheral QCT of the radius and tibia, or bone biopsies, we found that compared to controls, both the IOP groups had in cortical bone lower thickness, density, and increased porosity, and in trabecular bone lower density, lower trabecular number, and then obviously if the trabecular number is lower, the separation of the trabeculae is higher, and lower stiffness. So basically what we found in our small study was that there were comparable deficits in women with fractures and those with only low BMD. So all this to say that I think you need to take a low BMD seriously when you see it and not just blow it off and say, well, what does it mean? I think it can mean something. When we looked at remodeling, it was very heterogeneous. We expected that everybody would have low bone formation, like when our male studies, but what we found was there really wasn't any difference between groups, and we found people with normal, high, and low remodeling. This is the shaded range is normal based on our controls, and this is the patients. These are the patients, so you can see that a lot of them had very, 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 very low remodeling, and some of them had quite high remodeling by bone formation rate. And it seemed to actually tell us a little bit about etiology, perhaps. So when we looked at tertiles of bone formation rate, we found that the women in the lowest tertile, you'd sort of think, well, they have low bone turnover, so maybe it's not so bad because they're not actively losing, but they actually turned out to be the worst off. They had the lowest trabecular bone volume and the lowest stiffness, and they had the lowest osteoid width and wall width. These are markers of osteoblast function, so it's not too surprising. And then they had also, back to the IGF-1 story, in contrast to the men, where IGF-1 and bone formation weight were directly related, we had an inverse relationship. So these women with low bone formation rate actually had higher serum IGF-1 levels. That sort of suggests maybe we're thinking about a IGF-1 resistant state at the osteoblast level. It's not a big difference, but it is, there was a significant difference. And then the women in the highest tertile, all these women up here, they tended to have less severe deficits in bone volume. They had higher urine calcium and PTH and higher 125D. So maybe they had a sort of a mild form of idiopathic hypercalciuria. And here's their 125D levels, significantly different. What about bone turnover markers? Did they predict bone formation weight on the bone biopsies? Probably you can tell what I'm going to say because otherwise I probably wouldn't have said it that way, but they really didn't. And here we have the actual measures of osteocalcin, and it's the same for CTX and bone alk phos. You can see that if you looked at the mean of these, it would go up. But if you're looking at any individual woman, there's going to be a lot of overlap between women in the lowest turnover group and in the high turnover group. So not really a very good way to try and assess whether the patient has high remodeling or low remodeling activity. You really need a bone biopsy to do that. So just to summarize, we found consistent deficits in volumetric bone density, microarchitecture, and stiffness everywhere we looked: spine, hip, radius, tibia, iliac crest. Heterogeneous turnover, which suggested varying pathogenesis, consistent with maybe primary osteoblast dysfunction or IGF-1 resistance at the osteoblast level. And I didn't show you these data, but they also had more marrow fat, even after controlling for the fact that they had less bone. So you could think, well, they have less bone, so there's more fat in their marrow. But even when you controlled for the less bone, they still had higher marrow fat, and I don't really know what that means. And they also had less mineral in the bone that they did have, so there was less concentration of calcium and phosphate in the osteoid. And they had very mature collagen crosslinks. So it was like, even when you measured collagen crosslinking right at the site between the two tetracycline labels where bone is actively forming, they had already something wrong with their cross-links so that they were more mature, even at a very early age. And more mature cross-linking is associated with fragility. So just to conclude, I think that in this group, this is a group where actually a bone biopsy can help you somewhat in trying to figure out what you're dealing with in terms of pathogenesis, and that bone turnover markers doesn't seem to be very helpful. And then just to reiterate, we really didn't find much difference between the fracture and the low BMD subjects. Now this could be selection bias, because who's going to come and have a bone biopsy? And maybe they have a reason to be worried about their bone, or maybe they're part of a continuum, or maybe the fractures were just due to happenstance and weren't really related to, we all know, I'm sure you've all seen patients who have the most horrific bone density in the world and they've never had a fracture, and conversely, you might have seen patients who have not so terrible bone density and have had lots of fractures. So fractures are kind of an imperfect endpoint in that regard. They're not always as related as you would think they might be to actual what you can measure in terms of bone density. Okay, so I'm just going to turn to talk a little bit about management in premenopausal women. So the challenge is whether to treat. And then once you've decided whether or not to treat or whether you have to treat, then another challenge is how are you going to treat these women. So in general, we always recommend adequate nutrition, calcium, vitamin D, exercise, and avoiding known skeletal toxins like tobacco and alcohol. And this makes perfect sense, but there have been studies done where they've done this with people and followed them over a year or so, and maybe their bone density might improve by 1%. So you have to, if you're going to do that, counsel people that they can't expect miracles. And there was one study that actually followed 16 women with IOP, and they just treated them with conservatively, and their bone density actually got a little better over 3 years, and they didn't have any fractures. But those are the only data I'm really aware of. The next thing is management really should focus, as I said in the beginning, on identifying the secondary cause, because often if you can correct it, this gives much larger increases in bone density than you might get with a drug. So looking at celiac disease, primary hyperpara, and controlling inflammation in people who might have inflammatory disease like RA or inflammatory bowel disease. Here's an example of parathyroidectomy. We had 12 women at premenopausal and 36 postmenopausal who had bone density before and 1 year after parathyroidectomy, and both had a 10% increase at the spine. There's not very many things that cause 10% increase at the spine bone density in terms of drugs. And here's a list of some studies that looked at bone density after a year on a gluten-free diet at the lumbar spine and the femoral neck, and often people who start a gluten-free diet will improve. In my opinion, it's very rarely justified to use pharmacologic therapy unless the patient's having major fractures, or if you're following them over time and you see that their bone density is going down even though you're treating it with conservative treatment, or their bone density is extremely low, say -3 without a fracture, then I might consider treating. And again, obviously, if it's getting worse. So if drug therapy is necessary, if you decide you're going to treat, it's very important not to give them SERMs because they cause bone loss in premenopausal women. They are a weak estrogen agonist, and they block actually real estrogen from binding to the estrogen receptor in bone, and they are associated with bone loss, as you can see when these drugs are used in women with breast cancer. Bisphosphonates, we all try to use them with caution in women of childbearing age because of their long residence in the skeleton and the fact that they cross the placenta. And in animal studies, high doses had adverse effects on the fetus. Although there's tons of case reports that say it's safe, God forbid that you should treat somebody and then something should go wrong, and how would you ever know? Now, we also know that teriparatide and denosumab are contraindicated in pregnancy. This is the data on raloxifene, SERMs, showing 27 premenopausal women who were at increased risk of breast cancer, and they took raloxifene for 2 years, and here you can see what happened to their bone density. Very big decreases at the spine, less so at the hip, with some recovery after stopping. Now there's a nice review, Ferrari et al., sorry you can't see it, in 2012 in Osteoporosis International, and they reviewed all the studies that had looked at either bisphosphonates or teriparatide in premenopausal women with various causes of secondary osteoporosis, and basically all the drugs worked. They all improved the bone density. But there's really the fact that they're really not FDA approved in premenopausal women unless they're on glucocorticoids, and also there's no data, like I talked to this morning, that doing that prevents fractures. And there's never going to be data because there's not enough people to do a study large enough to see. So we have done some studies. I'm showing our pilot study now that was published in JCNM in 2013. We took 21 of the women from our cross-sectional study, and they took teriparatide for 2 years. And they had bone densities every 6 months and biopsies at baseline in 18 months and HRPQCT. So there was about, on average, an 11% increase at bone density at the lumbar spine over 2 years. At the hip, about a 6.4%, 7.8% at the femoral neck, and no significant long-term change at the radius. And this is our patient. She participated in the study, and you can see what happened to her bone density when she took the teriparatide. So she got a lot better. And here we have the results of the bone biopsies. This is percent change from baseline versus 18 months. And there were increases in bone volume, trabecular number, cortical thickness, trabecular stiffness, but there was also an increase in cortical porosity. And this is our patient. This is her baseline biopsy, and this is her 18-month biopsy, with the caveat that they're on opposite iliac crests, and you have to try, I can't be precisely positive that they were at the same site on each side. We do the best we can, and I'm not going to show you the HRPQCT data because I think this is a little more important. Here, we also noticed that 4 of the women didn't respond at all. They didn't, by 12 months, they didn't have any improvement in their bone density. There was a little uptick at 18 months, but then it sort of went back toward baseline. And they also didn't have any increase at the hip. And we found that the responders, the non-responders, had significantly lower bone formation rate at baseline. So that's kind of sad because we were hoping that these people with low bone formation would respond to teriparatide, which is an anabolic agent. And some of them did. Some of the women with low bone formation did, but these 4 women did not. Okay. And we also found a direct response with baseline bone turnover, so that the higher the baseline bone turnover, the better response they got on their biopsy. And again, back to the IGF-1, we found that in the non-responders with the low bone formation rate, they had a higher serum IGF-1. So again, a little bit of a support for our hypothesis of IGF-1 resistance. And there was a weak but inverse relationship between the serum IGF-1 at baseline and so the higher the serum IGF-1 at baseline, the less of a response they had in terms of their lumbar spine BMD. So we have been conducting, we just finished, actually, we submitted to ASBMR the first year data from an FDA-funded randomized clinical trial of teriparatide in premenopausal osteoporosis. It's a placebo-controlled single switchover trial funded by the FDA, Orphan Diseases Branch, and the primary outcome was lumbar spine bone density by DEXA with other secondary outcomes. And we did a quadruple labeled transiliac biopsy at 3 months in 35 of the 41 women. So what we do is we give tetracycline, two courses of tetracycline. One is before the biopsy, before they start teriparatide, and one is at 2.5 months. So we can measure bone formation rate before they're treated, and then after they've been on treatment for a while. And this is what it looks like. Here is the first label that was given pre-teriparatide, and here you can see way more. You can see there's much more bone formation going on at the 3-month point than there was at the baseline point. You can see this there. So we randomized 11 women to placebo first and 24 to teriparatide, and then at 6 months, those randomized to placebo switched to teriparatide. So it was a single switchover study, and then everybody got 24 months. And we're presenting the 6 and 12-month data at ASBMR. Here we have the bone formation rate in all 3 bone envelopes. Here's cancellous, endocortical, and intracortical. These are the placebo patients before and after teriparatide, and you can see that in every envelope we had a very big response in bone formation rate, as you were expecting. And we did this because we wanted to confirm our pilot study data that showed that there was a direct relationship between bone formation rate and response. And the results so far, during the first 6 months, bone density increased more in the active than the placebo group, as you would expect. 5.5% in 6 months versus 1.8%, and that was significant. And there were no significant differences at the other site. And during the first 12 months on active teriparatide, bone density increased by 8% at the spine, 3% at the total hip, and 2% at the femoral neck. We did notice in our pilot study that most of the improvement at the hip was in year 2. And as in the pilot study, we had 20% that didn't respond at all. So that seems to be a fairly consistent finding. And we're looking at the predictors of the 12-month bones response, and we found significant predictors were the baseline bone formation rate, as we saw before. The higher it was, the better the response. Also the 3-month bone formation rate, the higher it was, the better they responded. The change from baseline, the bigger change they had from baseline to 3 months was directly related to DEXA response. Baseline CTX, the higher it was, the better they responded. And the R values were all about 0.4 to 0.5 and statistically significant. The 24-month results we think will be available for early in 2019. The last patient finishes 2 years next January. So what about after teriparatide? We know that in postmenopausal women and men, BMD declines after teriparatide is thought if it's not followed by anti-resorptive therapy. We wondered, because these women are menstruating and they have estrogen, and because we know that postmenopausal women on estrogen keep the bone at least for a couple of years if they've been treated with teriparatide, we hypothesized that maybe these women would hang on to the bone they gained, and that enough endogenous estrogen production would be there so that you'd prevent the bone loss. And what we found, these are 15 women from the pilot study who came back and were rescanned at 2 years, and this is what happened during the first 24 months, and this is what happened after they stopped. So they lost about half. And bone density was stable at the hip and femoral neck. And interestingly, those who lost significant bone mass at the spine were older, so mid-40s versus 38. So it looks as though maybe estrogen might help if you're young enough and you have lots of estrogen around, but maybe once you get over 40, you might not have enough endogenous estrogen production. So I think this means there may not be much point in treating somebody with teriparatide for a while unless you're prepared to have a treatment plan for what happens after teriparatide. So I think the answer is, especially older women probably need follow-on treatment after they finish teriparatide. And the question is, what should we use? So I think it depends on the clinical situation. So in some people, estrogen replacement may be a good idea. In some people who are not going to have any more kids and a little older, maybe bisphosphonates would be a good idea. What about denosumab? There may be the possibility of future anabolic therapy, anti-sclerostin antibodies. So I'll tell you a little bit about what we're doing in that regard now. So these are a few other studies we're working on. Right now, we've just got whole exome sequencing of the phenotype cohort of 104 women with IOP. We are just getting those data back. There's no one genetic abnormality. There are a couple of people with different ones, and we're just working with the genetic counselors now to figure out which of these mutations are really possibly disease-causing. But that's sort of going to be coming out soon. And then we also have another phase 2b study of denosumab to prevent bone loss in these women who finished the teriparatide study. So this is another R01 that's funded by the FDA and by Amgen. And it's only for subjects who completed the teriparatide study, and we've enrolled 30 subjects to date. And they can choose to take alendronate or be observed or take denosumab. So far, the vast majority have chosen to take denosumab. And they can take it from anywhere from 12 to 36 months. And so far, we just took a quick look at this is open label, and we took a quick look at the first year on denosumab, and they have an additional, in addition to what they got on teriparatide, an additional 6% improvement in bone density at the spine. So that looks like it's going well, but again, what about after denosumab? Because new data indicate there's an increased risk of vertebral fractures in women who stop denosumab, and a lot of our patients had vertebral fractures, and going into it, and those people are at higher risk. So we now have a study looking at bisphosphonate therapy in these women. They can choose which bisphosphonate they want to take. We're not randomizing them because some people are just deathly opposed to zoledronic acid and taking something that lasts a year, and some people are opposed to alendronate. So we're allowing them to choose so that we can gather data on what would inform a young woman of this age decision to make. And this study is supported by Amgen, and we'll probably be submitting it for federal funding as well. So that's where we are now, and we're just starting enrollment in that study now. I think the first patient was enrolled in January. So I think what this is telling me, when I started out, I sort of thought, well, maybe, teriparatide could correct a temporary situation, and they might be all they need. But I think what I've learned in my evolution over taking care of these women is that you have to have a long-term plan. If there's somebody who's not willing to take an anti-resorptive after teriparatide, and that going in, maybe it's not any point in treating them with teriparatide because the bone may go away, especially if they're older. So I think you have to approach these women with a long-term plan and say, look, we're going to do this now, and then when that's finished, we're going to consider these other options, and just, you have to reassure them that you're going to be there to take care of them, and that it's not going to be a one-shot deal and then they're going to go off into the sunset, and that you have to be willing to go on from there. And if you're not willing, then I don't think they should be treated, because I think what's the point in giving them a drug that costs $45,000 a year and is, that's temporary if you can't really maintain the gains. So I think that's informed me, and that's why I say there's rarely a reason to treat these people unless they're extremely severe. They're getting worse on therapy. You can't find anything else to do. They're having continuous fractures.